And now I would like to introduce today's speaker, Dr. Parag Goyal. Dr. Goyal is an associate professor of medicine with joint appointments in the Division of Cardiology and the Division of General Internal Medicine. He is the founding director of the Heart Failure with Preserved Ejection Fraction Program and is the director of the Cardiac Amyloidosis Program at Weill Cornell Medicine. Dr. Goyal's research program is focused on improving outcomes in older adults with heart failure through optimization of medication patterns. His program is supported by grants from the National Institute on Aging, the American Heart Association, the Fan Fox and Leslie R. Samuels Foundation, and the New York Community Trust. Nationally, Dr. Goyal is an active member of the American College of Cardiology, where he currently serves as the chair of the Geriatric Cardiology Early Career Professionals Working Group. He also serves as the Geriatric Cardiology Section Editor for the Journal of Cardiac Failure and sits on the editorial boards for the Journal of the American Geriatric Society and JACC-Advances. Now I'll turn it over to Dr. Goyal.
Thank you. Thanks for the kind introduction. It's really great to be here and talk a little bit about N-of-1 trials to promote deprescribing. When the U.S. Deprescribing Research Network started, I actually had the opportunity to serve as the inaugural part of the inaugural cohort of junior investigator intensive cohort. So learned a lot from them, tried to infuse some of that in the work that I'm doing, and it's super exciting to share some of that work here. So here are disclosures. Of note, I have a pilot grant from the U.S. Deprescribing Research Network, which I will touch on later. So the agenda here is going to be, I'm going to start by talking a little bit about inspiration, give a little bit of background on how I, as a heart failure cardiologist, got interested in polypharmacy and deprescribing. Then talk a little bit about innovation, this idea of leveraging N-of-1 trials to promote shared decision-making and promote deprescribing. And then I'll end with an illustration, which is really a case example of some of the work that we've been doing. So let's start with inspiration. So as mentioned, I'm a heart failure cardiologist. And as a heart failure cardiologist, we prescribe a lot of medicines. So this is the pathophysiology really of heart failure. And what you're seeing in the blue text are a bunch of medicines that actually target some of the pathophysiologic factors of heart failure. In addition to all those medicines, there's a host of medicines over the last 10 years that have also been approved for use in heart failure. And these are just a few. And all of this is to just make the point that there are a lot of medicines out there that can treat heart failure, many of which I prescribe. In addition, patients with heart failure often have a host of other medical conditions beyond heart failure. So that includes other cardiovascular conditions like atrial fibrillation and coronary artery disease, as well as a host of non-cardiovascular conditions. So this depiction really is just showing that multiple chronic conditions is nearly universal in these patients. Nearly 50% of patients with heart failure have 5 other medical conditions. I make this point because it's no surprise that once you add up the heart failure medicines and the non-heart failure cardiovascular medicines and all the medicines to treat their non-cardiovascular conditions, you can see that the number of medications can really increase very quickly. Patients, ambulatory adults with heart failure, take a lot of medicine. This is just a histogram from data from N. Haynes from a few years ago, showing that 75% take at least 5 medications, a common definition for polypharmacy, and 25% take at least 10 medications, which is commonly used as a threshold to define hyperpolypharmacy. When you talk about hospitalized adults with heart failure, they take even more medicines. Nearly all of them take at least 5 medications, and 57% take at least 10 medications. So again, you can see that patients that I primarily take care of, patients with heart failure, take a lot of medicines. So early on, when I joined faculty, I did a qualitative study to just better understand really the patient journey with heart failure and some of the challenges that they face as I became interested in trying to improve outcomes and also well-being of older adults with heart failure. And this quote, I continue to share this quote in many of talks that I give because it really stuck with me and has really inspired and driven a lot of the work that I do. So I'll read it to you. This is from a real patient with heart failure as part of a study. And what they shared is, because I take so many medications, there are times I wonder, is this one hurting me or is it helping me? there's always a question about the number of medications I'm taking and if they're doing what they are supposed to do. I think it's easy to dismiss that, well, they take lots of medicines. That's definitely not what's harming them. But I think many on this call will recognize that actually patients may very well be right when they share with you that their pills are actually making them worse or making them sick. So the idea, very simply, the principles of safe and effective prescribing practice: prescribe agents whose potential benefits outweigh the risks, and deprescribe agents whose risks outweigh benefits. And while most of the heart failure world has really focused on that top part, there's a lot of work being done to optimize prescribing. I actually became interested in the deprescribing part. Naturally, this is the one definition of deprescribing that's out there. And so that really is what has inspired me as a heart failure cardiologist to be interested in polypharmacy and deprescribing. The next natural question, of course, as a clinician, but also as a scientist, is, well, how do we actually do this? So that brings me to innovation. So this was another qualitative study that we did of older adults with heart failure. And in this study, I was really interested in understanding patient attitudes toward their medicines, and in particular, potentially deprescribing or stopping their cardiovascular medications. And one thing that we learned and developed from this work was to refine a pre-existing conceptual framework to understand barriers and facilitators. But in addition, during those interviews, we also learned a bit about what patients were interested in to facilitate potentially stopping or deprescribing their medications. And I'm going to read a few of these quotes. These are quotes from patients with heart failure in particular. And in particular, I was actually, for this section, I was asking them about beta blockers and possibly stopping the medication. Here are some notable quotes. If my doctor wanted to temporarily stop the medication, I would be open to that. I would just say, let me try it, at least for a while. Another quote, I would go with the way I feel. If without the medication, I feel better, I'm not taking the medication. Another, suppose I don't feel better and I start feeling worse. I feel like I should be able to get back on the medicine. Is it, discontinuation, making a difference now, or is it making me feel better or worse? I would have to pay attention to it and see without the medicine how I'm feeling. So I'll summarize these quotes and what I was thinking about several years ago as we collected this data and were synthesizing it and trying to figure out learnings. First, patients are willing to temporarily stop their medication, but they want the opportunity to go back on it. They want to understand how they feel without the medication. They want to be able to go back on it if they feel worse. And really, they want the opportunity to actually have that data and make decisions based on that data. And so I would argue, really what they're describing, in a way, are N-of-1 trials. So what are N-of-1 trials? So it's a type of study design which is unique and different from parallel or crossover study designs. So as a reminder, for parallel study design, half the population gets treatment A and half the population gets treatment B. In a crossover population-based study, half the patients get treatment A, half the patients get treatment B, and then you swap them so that the patients that originally got A then get B, and the patients that originally got B then get A. In an N-of-1 trial, it's actually not about the population necessarily. It's about an individual patient. And in that individual patient, it's about testing multiple different interventions. Patients previously had shared that, well, they're willing to try it, but they want to go back. They want to be able to go off it. Really, what they're describing is a little bit that they're willing to do a little bit of trial and error. To me, N-of-1 trials really are kind of like trial and error, where in a patient, you try one treatment and then you try a different treatment, except the difference in what I see the value in N-of-1 trials is adding rigor, collecting data in an objective and systematized way so we can better understand how patients feel on one treatment compared to another. In particular, for deprescribing, I would view treatment A as, say, stopping a medicine or being off a medicine, and treatment B of being on the particular medicine. And the idea of N-of-1 trials has been around actually for many, many years. And there have been several studies examining the value of N-of-1 trial for a host of different clinical circumstances and outcomes. In particular, this study, which was published a few years ago in JAMA Internal Medicine, looked at the role of N-of-1 trials really to determine the optimal treatment for chronic musculoskeletal pain. I want to bring your attention to this box up on the right. Shared decision-making was actually a secondary outcome for this study. But what they showed was that N-of-1 trials in their study actually improved medication-related shared decision-making. So N-of-1 trials seem like they can actually improve decision-making. In addition, N-of-1 trials can promote deprescribing. This is a review paper from a few years ago from Sarah Helmer and others who looked at previous N-of-1 trials that studied the very specific purpose of deprescribing and showed some success in terms of deprescribing the medicine. In addition, we all know that there are many barriers to deprescribing. One way that I think about some of these barriers, and there's a lot of conceptual frameworks out there, include patient-based barriers, physician-based barriers, scientific evidence-based barriers, and health system-based barriers. And I would argue that N-of-1 trials actually can combat some of these and facilitate deprescribing. So at the patient level, N-of-1 trials can account for biologic heterogeneity of older adults and variation in health priorities. Again, it's about one patient. They can provide individual level experience and quantifiable effects to facilitate effective decision-making for patients. It can reduce patient feelings of uncertainty and conflicting attitudes toward deprescribing. And it can, as mentioned, facilitate decision-making based on objective data, regardless of who is helping to make the decision, whether it's the patient who wants to make a decision on their own, or with the caregiver, or with their closely with their doctor. There are also a host of facilitators at the physician level in terms of N-of-1 for deprescribing. N-of-1 trials can facilitate decision-making about deprescribing, again, based on experience, and they actually mitigate some of the preconceived biases that are well described that clinicians often have, or that we often overestimate the benefits and underestimate the harms of medicines. The data collected from N-of-1 can also provide a platform for discussions between physicians across different specialties and can facilitate communication regarding the potential utility of deprescribing. At the science level, it can permit a comparison of the short-term effects of continuing and discontinuing a medicine, generating individual level evidence for the effects of deprescribing. And by doing so, can also facilitate therapeutic precision in the face of inherent complexity of older adults. And then at the health system level, with the right setup, N-of-1 trials can actually potentially circumvent the time constraints of clinical encounters, provide a scaffold for shared decision-making, and actually improve patient understanding of the deprescribing risks and benefits. Hopefully I've given you a little bit of a background of where I'm coming from, why I got interested in N-of-1 trials, talked a little bit in theory of what N-of-1 trials are and why they could be used to promote shared decision-making and deprescribing. I'll finish in these next 5 or 10 minutes really talking about a case that I hope will illustrate some of these principles. And then we purposely left plenty of time for question and answer after this brief presentation. So in particular, we are studying N-of-1 trials for deprescribing beta blockers in HFpEF, or heart failure with preserved ejection fraction, which is a condition that I specialize in, and these are the majority of patients that I take care of. As you heard at the start, I lead our heart failure with preserved ejection fraction program. So it turns out that a very high proportion of patients with this very specific subtype of heart failure take beta blockers. In some of the most recent randomized controlled trials, 80 to 85% of these patients take beta blockers. And yet the evidence, the clinical trial, randomized controlled trial evidence for beta blockers is minimal. There was one study actually that was done. And as you can see here, it was a neutral study. No clear benefit of beta blocker. There's some observational data showing that beta blockers may actually be harmful. This is an observational study of TopCat, which was which was a randomized controlled trial of patients with HFpEF from several years ago. They did a propensity score match and compared patients who took beta blocker at baseline and those that did not take it at baseline. And the cumulative incidence of various cardiovascular events was increased among those taking beta blocker. There's a small study, again, the study population is patients with HFpEF, where deprescribing beta blocker was actually shown to be beneficial, and in particular, beneficial in improving exercise tolerance, which was measured here by a cardiopulmonary exercise test. I won't go into great detail here. There were 52 patients. Patients went on a bike to assess their exercise tolerance while they were taking the beta blocker. The beta blocker was stopped and it was repeated. And what this is basically showing is that their exercise tolerance was improved. Some people might say, well, patients with this type of heart failure, they have other indications for beta blocker. And it turns out about 40% of patients with HFpEF who are taking beta blocker actually don't have a great indication to begin with. So to summarize, there's no good clinical trial data showing benefit of beta blocker. There's some observational data showing potential harm. There's a small study showing withdrawal might be beneficial, and a bunch of these patients actually don't have other indications anyway. When you talk about, and the numbers are significant. So we're talking about there's 3 million people with HFpEF in the US. Most of them are on beta blocker, and about 40% of them don't actually need it. So we're talking about over 1 million people that are on this agent that may not actually need it and may be suffering harm. So that's the rationale for why I, in my career, have decided to really hone in on deprescribing beta blocker. And for the reasons that I outlined earlier, I felt like, well, maybe N-of-1 trials can actually promote this. So to do N-of-1 trials, there are some important methodologic considerations. So I'm going to outline some of those considerations, and I'm going to go apply it to this very specific case example. So one, to do N-of-1 trial, you need to determine whether N-of-1 trial methodology is suitable to the clinical question of interest. And that relates to, well, there needs to be some degree of clinical uncertainty about the medicine. And, I would argue, even though I showed you some fairly compelling data that why are we using beta blockers, the field continues to use beta blockers pretty commonly. And so you could make the argument that maybe there is equipoise here and that there is sufficient clinical uncertainty where an N-of-1 trial would make some sense. Two, you need to have a chronic symptomatic condition with stability, and HFpEF is indeed a chronic symptomatic condition, and the patients that we enrolled were ambulatory patients who were stable and did not have any recent changes in their medicines or clinical condition. And then the agent that you're essentially testing has to have a reasonably rapid onset and offset, and beta blockers indeed do have that. The second consideration was selecting a reasonable trial duration, a reasonable treatment period length, and sequencing scheme. So for a trial duration, we decided that, well, we need to have at least 2 what we call periods. We actually offered options to do additional periods. And what I mean by a period is period number 1 was some intervention. Period number 2 was another intervention. And then period number 3 and number 4 and subsequently could be repeated. In this case, the 2 interventions were continuing beta blocker, and we were interested in comparing it to stopping beta blocker. So we required at least 1 arm of each, 1 arm of on and 1 arm of off. We decided that the treatment period length should be based on the therapeutic half-life of beta blocker and the beta receptors that are actually upregulated when people take beta blocker. And when we did the calculation, we found that there were I think it was 6 or 7 half-lives that occur over the span. 1 week gives you about 6 or 7 half-lives, which gives you pretty good confidence that you've been able to clear out most of the beta blockers. So we went with a treatment period length of at least 1 week for each dose. And the way we did it is we cut the dose by 50% each week. So what we don't want to do is stop a beta blocker cold turkey. If someone takes metoprolol 200, for example, we don't want to just stop it flat out. What we want to do is cut it by 50% every week. And so for someone who was taking, for example, 200 milligrams, the duration of the period would take 4 weeks to get them off the medicine. And then for every period, we allowed for 2 weeks where they were off the medicine completely. It was at that stage that we collected some of the data. In addition, you need a sequencing scheme, and we actually randomized patients to either an AB-AB or a BA-BA scheme. And what that means is either off-on, or on-off, on-off. Other important methodologic considerations. It's important to invoke a suitable washout period if indicated. And so I just sort of outlined how we calculated the treatment period length, and I outlined that it was long enough to ensure that multiple half-lives had passed. And so we were pretty confident that after a week of cutting the doses by 50%, depending on what the starting dose was, we were confident that, and then giving 2 weeks where they were off the medicine completely, allowed for a sufficient washout period so that when we evaluated how they felt, we were convinced that they were no longer actually on the medication, the beta blocker. You have to decide whether or not to invoke blinding. And maybe this is a topic that we can talk about in a little bit more detail during the question and answer. We actually did not invoke blinding or placebo, and there's a few reasons for that. One is, on a practical level, I envision that N-of-1 trials could serve as a tool to be used in real-world practice. And I think that blinding and placebo in real-world practice isn't really feasible. The second is that, and I think many on the call will be very familiar with this, when we stop medicines, there's a physiologic or a biologic effect, but there's also a psychological effect or a psychological process that's ongoing. And for our purposes, and again, I'd welcome discussion of this in a little bit, for our purposes, we actually felt like we wanted to embrace some of those psychological processes. So actually keeping this open, that is not blinded, having patients recognize that, okay, we stopped my beta blocker today. I actually wanted patients to be conscious of that, and I wanted to collect the effects on how they felt incorporating that piece. The next step is to select suitable outcome domains and measures. And so we measured patient-reported outcomes. In particular, there's a heart failure-specific quality of life measure that we use, which is the Kansas City Cardiomyopathy Questionnaire. And we used the PROMIS questionnaire, which are health agnostic and is supported by and developed through the NIH. And then we also collected some physiologic measures and some safety data. And then finally, you need to analyze and present data to support clinical decision-making. And we applied the necessary statistical methods, and we shared data, and I'm going to show you how we shared in a few minutes. So here's a little more detail of what we did with our N-of-1 study design, where there was a period of on, there was a period of off, there was a period of on and a period of off. The number of weeks as outlined would depend on the dose that they were on, because it takes time to down titrate higher doses compared to lower doses. And as outlined, at least 2 weeks, patients for off in particular, patients for the last 2 weeks were off medicine. So I'll give you a typical example. If a patient followed this schema, for the first 6 weeks, they might continue on their metoprolol 100 milligrams. Then for the off period, during week 7, they would be down to 50. And week 8, they'd be down to 25. In week 9, they'd be down to 12.5. And then subsequently, the final 2 weeks, they would be off medicine completely. This is a calendar that we provide patients to help guide them in terms of following the regimen. And then for safety purposes, what we've done is we called patients multiple times during the week, not only on the day that they were supposed to change their dose or decrease their dose, but also the couple of days after, to see how they were feeling and to elicit whether or not they had any sort of side effects or perceived side effects. In addition, we gave them, we wanted to assess their vital signs, in particular blood pressure and heart rate. So we gave them a blood pressure cuff, which could also assess heart rate, and we collected that information basically on a daily basis to ensure safety. And we incorporated what we called as red flag readings, where if the heart rate was higher than 100, or the systolic blood pressure was higher than 160, we called the patient to check in on them and see how they were doing. As mentioned, we also collected patient-reported outcomes. We collected the Kansas City Cardiomyopathy Questionnaire, which is a heart failure-specific health status questionnaire, and we administered that every other week. We also collected data on the PROMIS 29, which allowed us to collect information on multiple domains, including fatigue, depression, anxiety, sleep, physical function, social role, pain. And then we actually added an assessment on cognition. I've talked a little bit about how N-of-1 trials I view as a tool potentially for shared decision-making. Well, to move forward with shared decision-making, it is important to be able to share the data with patients. And so working with some partners, we developed these gauges, which we felt, and patients had given feedback that this was fairly easy for them to interpret and understand, so they could better understand how they felt across different domains while taking their beta blocker compared to how they felt when they stopped their beta blocker. So I'm going to share some preliminary data, and I would just ask that, I'll share some preliminary data here, which is from our pilot N-of-1 trial, which was actually supported by my K76, which is a Beeson Award. And so we did this among 9 patients, all with HFpEF, all taking beta blocker with a median age of 80. 8 of them were taking metoprolol, 1 were taking nebivolol. And it turned out the Kansas City Cardiomyopathy Questionnaire, which is a quality of life questionnaire, was better when you stopped beta blocker. We put them on, we did a cardiopulmonary exercise test. I alluded to this test earlier when I shared some of the early data that maybe withdrawing beta blocker is beneficial. And we found some improvement. We also found improvement when patients did what's called a 6-minute walk. That is a test commonly used in heart failure, where over the span of 6 minutes, we see how far patients can walk. And then not surprisingly, those patients who were off beta blockers had a faster heart rate and also had a higher heart rate with exercise. That's relevant because, well, when we exercise, heart rate's important. And so our findings are consistent with physiologically what one would expect. In addition, so at the end of the study, once we shared all of these data on how they performed and how they felt on beta blocker and off beta blocker, we asked them, okay, the study's over. We just collected some data. What do you want to do moving forward with your beta blocker? You started the study being on it. Do you want to keep taking it, or do you want to be off? And all 9 patients that we actually enrolled shared a preference for either decreasing or stopping their beta blocker completely. As mentioned earlier also, we're interested in figuring out, well, can N-of-1 trials serve as a tool for shared decision-making? So we collected data on decisional conflict scale, and we also collected data on shared decision-making from this shared decision-making 9 questionnaire. And what we found was that after engaging in an N-of-1 trial, we're comparing pre and post. After the study, there was less uncertainty. For informed, actually, the lower number is better. So they were actually more informed. And then for the shared decision-making 9 score, the higher score indicates more decision-making. So you can see a substantial increase. And so we drew the conclusion that participants felt less uncertainty, they felt more informed, and they perceived improved shared decision-making from N-of-1 trials. We are now engaging in a second N-of-1 trial, specifically focused on beta blockers and another heart failure syndrome. This is going to be cardiac amyloidosis. We're currently in the middle of enrollment, and this is actually a pilot grant that we have from the US Deprescribing Research Network. And maybe I'll have the opportunity in the future to share those results as those come out. So I'll summarize to say that deprescribing may be an important consideration for patients living with heart failure, especially given polypharmacy is nearly universal. N-of-1 trials can theoretically address several of the barriers to deprescribing. And based on some of our preliminary data, N-of-1 trials can potentially promote deprescribing and shared decision-making. So I went through that fairly quickly. I want to thank you all, and then I really look forward to the next 20 to 30 minutes to do some question and answer.
You, Parag.
Thank you.
That was great.
Yeah, thank you, Dr. Goyal, for your excellent presentation. To those attending, now's the time to use the Q&A button at the bottom of your screen to enter your questions. And we have one we can start with. With N-of-1 trials for deprescribing, is there a concern that it may be harmful to continuously take someone on and off a medication, even with washout periods?
Yeah, so it's a great question, and there's a lot to unpack here. So I'll touch on a couple of really key points and some of the tension that I personally felt. So one, we didn't talk really about the statistical considerations for N-of-1 trials, but for population-based studies, power is closely aligned with the number of patients that are in the study. For N-of-1 trials, it's the number of periods. So actually, the more that you repeat the periods, the more power and the higher confidence you're going to have in differences that you observe. One of the challenges with that we've found is we actually have interviewed patients at basically every phase of the N-of-1 trial to better understand, like, what's the experience been like? What did you like? What did you not like? In general, patients didn't want to do lots of periods. In fact, most patients only wanted to do 2. They wanted to get some data when they're on it. They want to get some data when they're off it. And although the N is small, the number of patients is small, pretty unanimously, patients were like, by the time we do on or off and we collect some data and I'm paying close attention to how I feel on and off, I already know what I want to do. And so, it's really important naturally to think about, have the patient at the center of these considerations. The goal of this is to help patients to better understand, well, how do you feel with and without it? And so although it would be great to do more periods, patients, for the most part, don't want it and feel pretty confident in their decision after just 2 periods. This ties into your question of, could it be harmful on and off, especially in medicine like a beta blocker where there could be rebound? There could be. What I would say is we were very careful to think through half-lives and make sure that we allowed sufficient amounts of time for washout. So I think the risk is fairly low. But what I will say is I have not had a sufficient concern so that after patients do a couple of periods, we actually ask them that we don't just stop the study. We ask them, okay, Mr. Jones, you've been on and off. You've maybe gone on and off a second time. Do you need more information? Do you want to do some additional periods to collect information? Or do you feel like you have sufficient data? So I hope I kind of sort of answered the question, which is that there's no evidence to suggest it's harmful. And I would argue we should do more periods to help patients figure it out. But realistically, patients feel pretty confident even after doing a couple of the periods. Which I'll add one more thing, because a natural question and something I've struggled with, and I've talked to mentors about this, including people like Dr. Steinman. I still think that even when you're doing fewer periods, by collecting data in a systematic way, I still think it adds more rigor than what we do in usual clinical care. We do trial and error in clinical care all the time, right? We start in medicine, and what really happens? We start in medicine, we see them 3 months later, we say, how do you feel? They say, oh, I feel better. You remember, you look at your notes, you started one medicine, and we say, yeah, it must be that medicine. I did a good job. Maybe, or maybe not. But this approach, at least, I think, adds a little more rigor. Okay, that was a long-winded question, but I hope I addressed some of the considerations related to that.
Jonathan, can I ask a quick question and follow up to that comment?
Yeah, please do.
Yeah. So Dr. Goyal, just amazing presentation. And I know we've been able to be privileged to see some of this work before, but you mentioned something about the on and off. And I know just in clinical practice in that translation, did you taper people or did you just stop them? Because you talked a little bit about half-lives. And I know the 2 agents primarily was metoprolol, but did you look at the doses? And then how did you work that in to ensure an adequate on and off? And then would you do anything differently if it was carvedilol? So I'm just curious from
Yeah.
your clinical lens.
So great question. And I should have left the slide in. I took the slide out because I was worried about time, but absolutely. So we determined a titration period for every different, we looked at half-lives for all beta blockers. And what we found is that half-lives range anywhere between 6 and up to 24 hours. And so if you give it a full week, where you decrease a dose, your multiple half-lives. And we decided for the sake of convenience and for helping patients figure out, well, what days do I change my dose? What days do I decrease my dose? We would change dose every week. Every Tuesday is when we change the dose. With regard to tapering, yes, we tapered the doses. And the way we tapered is we cut the dose by 50% every week. So if you were on the example I was sharing before, if you're on metoprolol 200, you cut it to in week 1, they're on 100 milligrams. In week 2, they're on 50 milligrams. In week 3, they're on 25 milligrams. In week 4, they're on 12 and a half. And in week 5, they're off. In week 6, they're off again. So we get 2 full weeks of being off medicine completely. By the way, we collect data actually throughout all of those. And so alternatively, if you take metoprolol, just the long-acting succinate, 25, during week 1, you'd go down to 12 and a half, and then week 2 and week 3 would be off. So the duration of period differed based on the medicine, the dose that they were actually on. And I should have kept that slide in, but next time I'll make sure I keep that in. Good question.
Thank you. Super helpful.
A follow-up question, and then I know we have a couple of questions in the chat, but just like as you think ahead to trying to change the way usual care looks, I'm curious like what you think are the things we need to know or how we might think about it from an implementation perspective.
Yeah, so we think a lot about implementation. I think that one of the ideas in advancing healthcare delivery that really resonates with me is studying implementation concurrently with effectiveness. So the next phase, we're trying to do a pilot hybrid effectiveness implementation trial, and we are interviewing. The reason why we're interviewing patients and physicians and caregivers is to better understand, okay, like how do we actually make this work in real world practice? What we've heard, and this is not going to be surprising to any of the clinicians, we can't rely on our clinicians to add this to the hundreds of other things that they're doing. So I think the reality is going to have to be there needs to be a separate, almost like, and we're toying with actually implementing this at our own institution, like an N-of-1 team or an N-of-1 service whose job it is to actually administer these studies and be responsible for making sure the patient follows the right schedule, eliciting the data that needs to be elicited. You know, I shared that we're collecting vital signs. I'm not going to have their usual doctor review that. I actually review that. Our team reviews that. And then we make sure we've got a strong communication method to communicate when there are concerns or there are issues. We're actually also working to develop an app. I don't know how it's going to pan out, but as we think about implementation, we're sort of realizing maybe an app would also be helpful to keep everything organized. So more to come. Quite a bit of more work needs to occur to really think through, if I want to get this into clinical practice, how do we actually do it? But I'd like to think that we're moving in that direction slowly but surely by ensuring that all the stakeholders are at the table. And by the way, the other thing I'll mention is for the N-of-1 in cardiac amyloidosis, which is funded by US Deprescribing Research Network, one of the requirements was to actually have a stakeholder panel, as many of you may know. And I actually think that's right on. You need people at the table who can help guide. We do stakeholder panels with clinicians quarterly, and we do the same for patients and caregivers quarterly. And we've gotten lots of valuable information that we will continue to think through. How do we incorporate it so that we can get it in clinical care sometime in the future?
Thank you, Dr. Goyal. Another question from our attendees is, did you get to use telemetry to collect any home data in your study?
So we used like a Bluetooth enabled blood pressure cuff and heart rate thing. So it could automatically be sent and we could review it. That's what we originally had used. I think that as there's a movement to better integrate remote monitoring with our electronic medical records, the hope is that that sort of thing will be a practical and pragmatic approach to incorporate into N-of-1 trials in the future.
And next, do you think your primary pro or PRO could be adapted as a daily assessment to increase the number of data points per treatment period and increase power without adding periods?
So the answer is yes. How do I want to? Our next, we're already conceptualizing actually our next N-of-1, which would actually be in heart failure with reduced EF. And we are incorporating daily EMAs, ecologic momentary assessments. So I do think that there is an opportunity to collect more frequent data in order to increase power, increase confidence. It's worth noting that actually patients asked for less, which is also sort of interesting, and I think gets to the complexity and heterogeneity just of people. And so I think this comes back to implementation science. You need to figure out I think a key principle in implementation science is to think about what are the pieces that are core and like central to the intervention that must stay, and what are the pieces that you can actually adapt and refine and alter based on the specific preferences of the sort of client, of the patient and of the physician. So more to come on that, but I think we need to be able to offer multiple modalities or formats.
Another question from our audience is, did you notice any differences between those on higher versus lower doses of beta blockers?
So it's only 9 patients. It is something that we can look at. I will share that I think the majority of patients, I may have had the median dose. I think the median dose was like 25 or 50. There were actually not a ton of older adults. I'm just thinking about broadly that I take care of that are on really high doses anyway. And so could there be a difference? Maybe. Is it worth assessing? I would say yes, but I don't have that data quite yet.
Okay. Another audience member, it's a little bit different, but might be another med that we would consider deprescribing. I noticed digoxin is in the heart failure treatment list. Is this med used at all now?
So it is. I will tell you, I often stop it. Given the narrow therapeutic window, I do think that there are some clinical circumstances where digoxin is warranted. I think it's also, you got to be very careful about withdrawal, because some of the withdrawal studies did show a worsening of heart failure, a heart failure exacerbation. But I would broadly say I think digoxin is high on the list of potential candidates. And now, would I do an N-of-1 trial for digoxin? I'm not sure. And the reason for that is it seems like when you withdraw digoxin, there is a substantially increased risk of heart failure exacerbation. I don't know if I would want to repeat that over and over again. So I'm not rushing to do digoxin there, but I do think it's reasonable to consider for deprescribing in general.
Our next question. What do you think of an N-of-1 design for drugs that cause physical dependence, where you expect an initial worsening of symptoms, but then a drop to baseline with a lower dose? Could you have an N-of-1 study where you slowly taper the drug, but you don't have the patient go on and off?
Yes. And I think there's value. So the idea of N-of-1 trials really are you're testing different interventions. So what could the interventions be? Well, it could be one of the examples I shared from that JAMA Internal Medicine paper were different pain medicines. So it could be 5 different pain medicines. Another option could be on-off, as I've done, but another option could just be testing various doses of a given medicine and determining whether it manages symptoms. And there are others who actually are testing that and leveraging it for that purpose.
All right, and I think pivoting back to a previously asked question, do you think eventually there should be a whole separate service which helps patients to deprescribe, as physicians are very limited for time and deprescribing often loses focus?
I think so. I mean, I think, Dr. Boyd asked the question about implementation, and there are many on this call and many in the US Deprescribing Research Network that are thinking about this very question. How do we actually get people to do it? I think consulting services who have the expertise and the know-how and the time and the dedication to do these things could help our clinicians, including pharmacists. That's right. Agree.
While we wait for maybe some other questions to come in from our audience, there is another one that's slightly off topic, but I think will be great to answer is, this talk's generated a lot of interest. There can be difficulty in changing provider practice issues and the importance of education. So what, if any, changes have you noticed in provider education, for example, NPs, MDs, DOs, or PAs, over the last decade to better include polypharmacy management?
Well, I can speak to for the cardiovascular world and heart failure world. I don't think anyone used the word polypharmacy 10 years ago. And now people are using it. People are doing subgroup analyses based on medication burden. I mean, people are talking about it. So, and then there were several recent cardiovascular conferences, and a couple of them were actually about stopping medicines. And so I do think the idea of polypharmacy is permeating. I think people are recognizing it. I think the cardiovascular field is also recognizing the term deprescribing, which showed up in a recent guideline, actually. They didn't give guidelines per se of when to do it, but it's starting to show up in guidelines. So I think I'm answering the question, which is to say people are paying closer attention. There's still quite a bit of work to be done, but I think there's been a lot of success just getting people to think about this already.
Thank you.
Did I answer
Nicole,
the question?
Yeah, I got some reactions that people loved your answer, so I think we're there. Nicole, did you have another question for?
Yeah, I do. Dr. Goyal, thank you. First and foremost, thank you for a shout out for stakeholders' engagement in the work that you're doing and the importance of their role in terms of informing implementation and patient preferences. I wanted to shift gears. I know we focused a lot on beta blockers. We spoke a moment just about digoxin, and I know you mentioned potentially doing work with HFrEF in the future. Have you thought about looking at SGLT2s and their role in managing heart failure and some of the complexity, especially in our older adults? So just curious about that, because I know there's a lot of questions in terms of safety. So I wanted to pause on that one in terms of other classes you might be thinking about. And then I do have a follow-up question to the guidelines too.
Yeah. So my own bias, experience, anecdotal evidence is that older adults with heart failure tolerate SGLT2 inhibitors very well. I have a number of patients that will come back to me and in the short term even say, I've got a lot more energy. And these are patients who I've tried a bunch of stuff. Symptoms have plateaued. I start them on an SGLT2 inhibitor and suddenly they're feeling a little, a lot better. I have other patients who don't really feel different, but I personally think the data is pretty compelling of its benefits in heart failure, regardless of whether you're talking about reduced ejection fraction or preserved ejection fraction. So to me, SGLT2 inhibitors are maybe a less compelling use case for N-of-1. I have taken the approach of I give it to everyone, I educate them, and what are the things to look out for. And yes, there are some patients that for whatever reason don't tolerate it very well, in which case I stop it. But that's my own personal views on SGLT2 inhibitor. Diuretics, on the other hand, might be an interesting use case for N-of-1. SGLT2 inhibitors help a little bit with diuretic. There are mineralocorticoid receptor antagonists like spironolactone and eplerenone. There are loop diuretics. There are different types of loop diuretics. And observationally, patients respond differently to these different medicines. And often what I do as a heart failure doctor is I'm trying to figure out what is that right cocktail, which to some degree is trial and error, but I haven't yet used N-of-1, and maybe this is another use case.
Awesome. Thank you. And then just a preference from yourself as a prescriber, especially specialist and cardiologist. Where in treatment guidelines would you like to see deprescribing? We'd like to see it more, obviously. But if you were to look within the guidelines, any sort of area that you would like to focus on? Because I feel like just, a section, but I don't think it's necessarily in all guidelines. So any thoughts there?
Yeah, I mean, I think the culture of medicine is you start a medicine and then it just continues forever and ever. So, we can all talk about med reconciliation, but I think to some degree, I still almost feel like most people, when you talk about med reconciliation, it's, oh, well, are we abiding by the guidelines? Which automatically means, did I start all the right medicines? And very rarely are people thinking about med reconciliation to abide by guidelines related to getting rid of medicines because they don't exist. So I do think that there's a role to formally incorporate things like deprescribing in guidelines. I'd have to think more of what that might look like. The obvious ones I think would be expired indications. I could probably think of a few different versions of expired indications where it's like the best example is after you get a stent, there's a movement. First, you start with what's called dual antiplatelet therapy, and there's a movement to get rid of one of them. Well, that's actually a form of deprescribing. I think that would be great to more formally go and call it deprescribing, because I think that's what the field of deprescribing is calling it. It's interesting. I'll add one other thing is that I had the opportunity to participate in a scientific statement that the AHA put forth related to cardiovascular actually palliative pharmacotherapy for end-stage cardiovascular disease. And it wasn't, how would I say this? That's not the only setting in which deprescribing is relevant. And actually, the conversations we had as a group were consistent with that. People are recognizing that there's a role for deprescribing beyond just palliation. And so, again, all of that is to say, I do think there's a role. I'd have to think about how to structure it, but I think it'd be great. I think it'd be very holistic and comprehensive and complete if we moved in that direction.
Love it. Thanks, Dr. Goyal. I know, Jonathan, there's 2 more questions in the chat, so I'm going to be mindful of that.
Yeah, thank you, Nicole. Dr. Goyal, I think there's been a lot of findings out there from those who practice in primary care or general practitioners, around the globe, that share that there's barriers to deprescribing when a cardiologist or a specialist have prescribed a medication for the patient. So they're wondering, have GPs or primary care physicians told you why they are so reluctant to change or deprescribe a cardiologist prescription or any specialist prescription for that matter?
So we have done surveys, actually. There's probably people on this call who are involved. I think Dr. Steinman, for one. We've done surveys to better understand potential barriers to deprescribing cardiovascular medicines. And what's interesting is a key barrier is concern about interfering with another physician's treatment plan. Now, what's kind of interesting is not only did the primary care docs state that as one of the more common reasons why they don't want to stop cardiovascular medicines. The cardiologists also stated that as a pretty common reason why they don't stop cardiovascular medicines. So, I mean, I think just like with any medication management, I think communication is really, really critical. I think that it'd be great to get to the point where if a primary care doctor feels like maybe a cardiovascular medication isn't really indicated anymore, that there could be a smooth communication and a smooth way of figuring out together with the patient, does this make sense to continue or stop? As many on the call know, I think too often the medicine, again, is just continued forever and ever and ever because no one took the initiative to actually look at it and be like, wait a minute, what are we treating here? So my answer is we need just better approaches for communication. And I think maybe the N-of-1 idea could do that because you're generating evidence, we're having conversations with patients, and then we actually have developed a report that we put all the content of the conversation, the adverse events, the vital signs, the dosing history, the patient-reported outcomes, all in a single report, and we actually send it to the docs. We're still getting feedback on whether they like it or not. So far, so good. But yeah, it's a challenge.
Yeah, I definitely agree on trying to open up the communication between providers. For our final question of the day, could you please comment on the consent process and how many participants you needed to approach before you recruited 9 patients? And I think touching on the theme of power that you touched on earlier with 9 patients and only 4 periods per patient.
Yeah, so the number of periods we've moved where it's kind of adaptive now. So you got to have at least 1 period on or 1 period off, but it's now adaptive and open for patients to decide if they want more information. In terms of the consent process, we include, I didn't talk in great detail about inclusion-exclusion criteria, but basically we excluded people that had other clear, compelling conditions for beta blocker, because those are not the patients who we want to be deprescribing beta blocker. It's the people that don't have an indication and yet they're on it. And as I outlined, there's probably over 1 million people that have that. So when we call patients, and usually my team will talk with them and outline some stuff, but then I will talk with most patients before they actually provide consent, I'll share that rationale, which is that, look, like you're on a medicine, you don't really have a great indication. It's possible you're going to feel better without it. We don't know. Everyone's body is a little bit different, but we've got this idea where rather than just you continuing it, let's be systematic and scientific about it. Let's collect some information about how you feel when you take it. Let's stop it in a safe way. Let's see how you feel without it. And then I'm going to give you that information. I'm going to share that information with you about how you felt. And together we're going to figure out, do you really want this medicine? Or do you think, well, actually, I feel better with it?
Awesome. Well, thank you, Dr. Goyal, and thank you for all attending today's webinar. Our next webinar will be in December and featuring Dr. James Shepard on the Optimize trial. The recording for today's webinar will be posted to our USDN website soon. Please complete the after webinar survey that will be sent to you soon. And thank you and have a great rest of your day.
Thanks.